at the moment doing is to empowering people with their rights. Because people have lots of rights people don't know. Unless you can make the government involved, you cannot make this program sustainable. In order to make the government involved, you need the people's voice. And in order to make the people's voice, we need to empower them with the rights and the knowledge. Because that's the kind of sustainability. Because IDF cannot sustain, or even WHO cannot sustain a program for an indefinite period of time, but the local government. Because people with diabetes lives in a community, in a country, which needs to be taken care by the local government. The local government has priorities. And if people raises their voice, it will be the priority of the government. And there we need to work in order to make...
Welcome to Global Diabetes Insights, your go-to podcast for navigating the world of diabetes. I am Tino, a certified diabetes educator and a global advocate for non-communicable diseases.
And I'm Kona, a global advocate and a medical doctor. Together, we're your hosts, dedicated to raising awareness, fostering open discussions, and creating a safe space for everyone affected by diabetes.
Join us as we dive into empowering conversations with individuals living with diabetes, caregivers, healthcare professionals, and researchers. Our goal is to not only guide you through effective diabetes management, but also to inspire advocacy for proper healthcare access.
So get ready for a journey of insights, ideas, and diverse perspectives. Let's amplify our collective voice and create positive change. Get involved, get engaged, and join us in creating the change we need. So welcome everybody to Global Diabetes Insights.
Welcome to the Global Diabetes Insights, where we try to motivate people, bringing in amazing and big people in the diabetes field, also people living with diabetes. So today we have the honor of delving into this podcast with the extraordinary and amazing experts we have, the leaders in diabetes. For example, today we have the IDF president, International Diabetes Federation. So I'm going to allow him to briefly introduce himself to you. And mind you, today we are at the Pen Plus meeting conference in Tanzania, Dar es Salaam, the first conference that we are attending. So he will introduce himself. Thank you so much for being here.
My name is Akhtar Hussain. I'm originally from Bangladesh. By training, I'm a physician and a diabetologist. Currently, I work as professor of diabetes and metabolic disease at the Noor University in Norway. But I'm also the president of International Diabetes Federation, as has been introduced. So I live in Norway now. Just to say briefly that I have also worked in a number of countries other than Norway and Bangladesh. I have also worked in Africa, for example, in Tanzania, Zimbabwe, South Africa. I have also worked in Brazil, in South America, and a number of countries in Asia, and also a number of countries in Europe. So I have a kind of different types of experiences, both from the rich and the poor countries.
Wow, thank you so much. And I would like to say that I also have an affiliation with the IDF because I'm a young leader in diabetes, and also I am the Africa representative elect. He is the president for IDF. So it's a huge honor for me to host him on this podcast and also to bring his expertise because he's worked in a number of countries. First question that I have for Professor Hussain is for you, maybe just to share with us briefly what made him to focus all his career in diabetes.
It was actually a kind of personal experience. As I said, that my father, who actually died because of the complications arising from diabetes. Finally, he died of a cardiovascular event. That was my personal motivation. At that time, when I graduated in medicine, at that time, there was not much discussion that this is going to be a kind of world epidemic as the way we are observing today. Right. This was a kind of personal motivation, but then I realized that what I thought, it is becoming a kind of pandemic. But I must mention two people who was my mentor. One is Professor A.K. Azad Khan, who is the National Professor of Bangladesh. Another one is Professor Jack Jarbel, who was the previous president of International Diabetes Federation, who is also from Norway. Wonderful. So without these two people, probably I wouldn't be in diabetes actually. To say, yeah.
Right. So thank you so much. I think everybody starts from somewhere. For us as people living with diabetes, we're doing advocacy because we want to help change the narrative, because the things we saw, the things we're experiencing, we want to help change that. So for him, getting into focus on diabetes, because his family was also impacted by diabetes, and also having his father dying from complications is something that he's trying to change, as I see it, because he's a medical doctor. Maybe he didn't say that. Okay, so I'm telling you now. So I just maybe as part of background, I would love for you to say, like, if you can share with us, like, how has your personal experience with your father's diabetes complications influenced your approach in diabetes care?
That I saw the pain, particularly in resource-constrained societies. But of course, in terms of the drugs and the technicalities available today is far more than what he received. Let's say he died at relatively at an early age. He died at the age of 65. So he died many years back, and therefore the limitations that we had, I'm very pleased to say that we have overcome some of the limitations. The biggest challenge, however, is to see that how we can secure the accessibility to care, even though care is available, but it is not accessible to people, particularly those who are living in a resource-constrained society. And this is one of the motivation for me on the idea of how to secure accessibility.
I think accessibility, even at this conference, has become maybe the theme, although of course it's not the theme for the conference, but it is the theme because we're always talking of accessibility. It could be access to medications, it could be access to better trained medical professionals, and those are the people we need because we need to continue learning because things are changing. Diabetes is complex. So thank you so much for that motivation and also using that as your power, as your anger, to taking that as a motivation, and now you can inspire other people just by telling your own lived experience. So thank you so much. And now I think we are delving into the career and the experience that you have because you've worked in a number of countries, continents, I should say, not countries. But with your extensive career across like various countries, like I mentioned, how have these experiences shaped your approach to diabetes care and research?
As the way I see that my biggest competence to run an organization, to head an organization like International Diabetes Federation, those of you who are not familiar, the International Diabetes Federation stretches out to about now 176 countries of 243 member associations to deliver or to approach. And we say that we are the voice for 500 million people with diabetes around the world. Because no other organization in the world represents the globe other than the International Diabetes Federation for the people with diabetes. So we are the global voice for the people with diabetes. And having said it, the biggest challenge is, one thing is to say, but how do you secure the voice of those people who do not have voice? This is something that I struggle with. It is not that we want to give the voice to the diabetologist or to the endocrinologist working in the poorer countries. How do you give the voice to the people with diabetes who are helpless, who work in the field? It's a huge challenge. And I will have to say that we have not reached there. We are trying to secure the voice of the people, representatives from the people with diabetes from the poorer part of the world, who are not necessarily poor, who are not necessarily illiterate, who have a kind of, many of them have actually a medical education or in a very good position, even though they have a diabetes. So their voice is being secured to a certain extent to represent their countries. But biggest challenge is the way I see that how do you give the voice to the people who do not have voice in the resource-constrained societies? So that is the biggest challenge, and we think that it's a long struggle and we are not yet there.
Oh, thank you so much, and also for highlighting the challenges that we see, and also trying, also working towards targets, setting targets, because there are challenges that we see that are in existence. These are the things that we want to help change, and also having the patient involvement in it. I think that is really key, that is incredible, and everybody is emphasizing on it. So I thank you so much for taking that step further to focus on that in your career. So I think my next question would be, like, if you can share like some key initiatives or projects you are currently working on as president of the Diabetes Asian Study Group.
I actually started working on two key issues on the accessibility. If you look at for example, in Sub-Saharan Africa, is only 3 out of 10 people have access to insulin, life-saving drug. Globally, it's about 50% of the people with diabetes do not have access or not a regular access to insulin. So this is the situation. So I wanted to have a WHO resolution on universal access to insulin. That was the first thing that I tried to do. Unfortunately, I do not want to wish the name of the countries, the big and powerful countries in the world, 3-4 countries actually stopped this resolution. So we could not secure it. We had a kind of security, like, for example, saying the control of non-communicable diseases, etc., but not a kind of direct approach that I wish to see, and universal access to insulin. And that is because that's a life-saving thing. And I must say that those who do not have access, their human right is being violated. This is something that I hope that the next president and the president after, I must say that I had the opportunity to talk to the WHO. The current WHO leadership on the NCD, Dr. Bente Mikkelsen as the director, shares my views completely. And she is also a strong believer that we have not reached there, and we need to secure the accessibility to all people with diabetes. That's one of the things. But as you know, that IDF is more freer compared to the WHO. WHO as a kind of UN body, it has a larger bureaucracy compared to an NGO like IDF. So we have the leverage to take it further, at least to focus on this issue. So we are struggling, but we see that we do not have. We were afraid that the poor countries are not aware, but actually it is not. Actually, it is the rich countries who donates us but do not want to give us the right, do not want to give the universal access to insulin to all people who need it. This is the challenges that we are facing. Of course, I'm also involved in a number of other activities. We are developing new guidelines because we see that the guidelines that is being produced by the ADA or ESD is not appropriate for most of the people with diabetes living in the poorer part of the world. Because let's say that one analogs are AGL2s. So this is now, AGL2 is now enlisted in the essential medical drugs of the WHO. However, it doesn't give you the guarantee the government will supply you those drugs. The government says that if you do not have the money, we cannot assure you. So what is the best alternative? So IDF guideline is focusing on what is the right thing to do and what is the best alternative thing. Third thing is that what you should not do. So that is also important for doctors and the patients to know that what they should not do. Third thing that we have to say that in the poorer countries, that as the way I see, that the diabetologist and endocrinologist cannot see the huge number of people with diabetes that is coming up. The guideline focus is to see that with a video to enable the GPs at the ground level that they should be able to follow this guideline and they should be able to treat people with diabetes, because that's what is the reality on the ground. It is not America, it's not Europe. In the reality on the ground, in the most of the developing countries, the poor and middle income countries, is that GPs must be qualified to tackle the issue of diabetes in their clinic. We are also approaching with kind of fasting and diabetes guideline that many people are fasting nowadays, not only the Muslims, all religion has a sort of kind of fasting. Beforehand, we had one guideline we called Ramadan that is only for the Muslims, but I think that all religion has a sort of fasting. There is also fasting in terms of kind of the intermittent fasting or this kind of non-religious fasting. And this number is also growing. So we have not addressed, and the IDF as a global body cannot address only one religious fasting. So I have changed this thing, and I'm trying to create one we call the fasting and diabetes guidelines. So we are also created a kind of individual membership, because many people say that they are not part of an association, but they want to be part of the IDF and they are being denied their right, which is a real concern. So I have embarked on individual membership. Anybody, you don't need any qualification, anything, only that you are interested in diabetes, you could be a member of the IDF. So I made these changes. I'm also make these people more engaged, where I'm also engaged in creating one fellowship program that people can be recognized as IDF fellows in different parts of the world. There are new initiatives that are coming in addition to this guideline thing. Individual members could be anybody. The people can also apply for IDF fellows to be recognized as somebody there that they have done something constructive for people with diabetes, because I think that we are not doing good in order to recognize the people. There are many people who are doing so many good things, or they're doing something and then we recognize, and then after we forgot the story. So we should be recognizing them so that they can have this recognition for their lifetime.
Wow, that is beautifully said. If I could just stop the recording now and say, wow, this is complete. Thank you so much for that motivation, for sharing all that, to say issues that are not being tackled by World Health Organization. We could not just leave everything to them. We need to do something as NGOs, as individuals. Some people might not feel like they want to work with any association in their country, but they may feel they want to contribute. So those people, if they get recognized, I think we can, it's a global village. Not one person can do everything. We can do things individually, and we need to come up together to recognize that work. We cannot try to repeat efforts on things that are already there. Not all fasting is Ramadan, for example. So it's good, I think, to create something universal in terms of fasting, something that will be helping people, because other religions, or they might also want to fast, but they are not from Ramadan. They don't follow Ramadan. Fine, I think we are going somewhere. So if there are people that might also feel like they want to contribute, I think there's an open call now that IDF is welcoming it. From the president, you heard it from the host. So thank you so much, Mr. President, for that one. My last question on the career and experience, I think I would want to also try to close it on the work that you do with IDF. Could you share some key initiatives or goals you are currently focusing on to improve diabetes care and awareness worldwide? Yes, I know that you mentioned some of the things, but if there are others that you haven't, maybe you may just try to mention them.
One of the things that IDF is doing, it was not started by me, the IDF School of Diabetes, that was started in 2016 by Dr. Shaukat Sadiqat, who was the then president. When I took over as president-elect in 2019, I became the responsible as the chair for this IDF school, and Dr. Samir Pathan, the senior manager for this. Today, you can say that when I took over, we had around less than 30,000 people. And today, we can proudly say that we have about 90,000 healthcare professionals all over the world. They are there because if we cannot spread the knowledge to the people, and these courses are not only for the doctors, it is also for the doctors, but it's also for the nurses, it is also for the health educators, it is also for the people with diabetes. What we want that the people should be equipped with the knowledge and powered so that they can manage their diabetes situation on their own. Because we have to see that the context that IDF is working is not only Europe or America, that everything is a universal health coverage. We generally have to take care of our condition by ourselves. So unless you are being empowered with your knowledge, then how you do it. So IDF School is a great initiative. Now I will ask all out, as I said, that even people with diabetes, you don't need to be a doctor, you don't need to be a nurse, you don't need to be anything. You have a simple diabetes, so you can simply take some courses. There are courses which is absolute free. There are some courses that we have to pay, because you know that IDF cannot sustain a kind of program indefinitely if we do not have any earning. But these courses are internationally recognized. These courses are accredited by the European Union,
right,
and also the American Medical Education's Continued Program. So it has been recognized internationally. The program is developed by Harvard. We have a kind of international faculty that who gives us this knowledge. So this is one of the vehicle that we want to, besides advocacy, we are going out straight to the people to make them empowered. The second thing that we should be also working, that which is not we are at the moment doing, is to empowering people with their rights. Because people have lots of rights people don't know. Unless you can make the government involved, you cannot make this program sustainable. In order to make the government involved, you need the people's voice. And in order to make the people's voice, we need to empower them with the rights and the knowledge, because that's the kind of sustainability. Because IDF cannot sustain, or even WHO cannot sustain a program for an indefinite period of time, but the local government, because people with diabetes lives in a community, in a country which needs to be taken care by the local government. The local government has priorities, and if people raises their voice, it will be the priority of the government. And there we need to work in order to create the kind of sustainable intervention programs to secure the rights and accessibility to care for people with diabetes.
Wow, thank you so much for these beautiful initiatives. Also for trying to expand more on the programs that were existing before you were president at IDF, like, for example, the diabetes school. I remember when I wanted to sign up on it, as just a person living with diabetes, I couldn't do it because I didn't have a medical background. I don't have a science background, but I'm a person living with diabetes. Now I know, like, I've heard some people say that they are part of this diabetes school, they're taking the courses. So thank you. It's actually good because you can get accredited, recognized for the things that you're doing. Because sometimes I know in Africa, you cannot just go and speak in the hospitals with people without any certificate to say. They'll say who you are. They want to see what you have for them to be able to believe you. So thank you so much for doing that training. Now we are focusing more on your professional achievements, because you've achieved a lot. You're a professor, you're a medical doctor, and a lot of things. You're doing research, you are in the leadership, you're doing everything. What are some of your most significant findings in diabetes research, and how have they impacted diabetes care?
I think that one of the most rewarding things that I do is the prevention.
Right.
Because if we say that, for example, today we are trapped in a situation that we are, this medical community, unfortunately, where I'm a member of, is not supporting prevention.
Right.
Medical community, together with the industry, they are making a lot of interventions, that is the medical interventions for those people who are suffering with diabetes, which is very important.
Right.
But it is equally important that we stop the inflow. Now, what is happening today, that because of these medical interventions, we see that people are living longer. Even though they are not free from complications, but they are living longer and longer.
Right.
But the inflow of the new patients are not, the doctor community think that it is not our responsibility, because our responsibility when you come to my patient, and which is a wrong conception.
Yes.
But if you are a medical person or any health professional in the field of diabetes, you must know that education is the treatment. Prevention is the care you are obliged to provide. And this, if you do not have any motivation, I will go to the point that you should choose some other specialties other than to go into diabetes or any other NCDs. Because NCD is a chronic condition that you have, once you have it, you have to live it throughout your life.
Yes.
So if you cannot educate them, if you cannot empower them, only medication will not help to have a kind of healthy life. Right. For these people. So I think that this is the important aspects, and therefore the number of people today is growing simply because the inflow of new cases are not stopped, but people living with diabetes are living longer. So total number, the accumulated number of people with diabetes currently is uncontrolled, you can say. But of course, it's good for the industries. They are selling more and more medicine. They are making more money than ever. So are the doctors. They are more busy than before. So doctors are asking for more hospitals and more healthcare professionals in the care of diabetes, but they are not engaged in the prevention in the first one. We have shown again and again, others have shown, I have also shown that lifestyle modification is the best measure. But lifestyle modification actually prevents from the incoming to diabetes world. But unfortunately, as you said, that people have started diagnosing the people who are at risk. For example, you said that the pre-diabetes, right? And pre-diabetes is a condition that you do not have diabetes, but you are at the risk of diabetes. Right. But pre-diabetes is a medical diagnosis. Therefore, WHO and IDF, I have changed it from the IDF side, aligning with the WHO. We are not calling anymore pre-diabetes. We are saying intermediate hyperglycemia, because this is a state. So we are putting it the name as intermediate hyperglycemia, so that the prevention with a lifestyle modification comes first. But the doctors, unfortunately, that they tend to write the medications while you are at the pre-diabetes. Of course, there are some people that we know that their lifestyle modification is not possible because of their inability, for example, any physical inability that they represent, or for example, those people who are genetically predisposed to develop the diabetes or obesity, for example, let's say that. So we can have a kind of special focus, but for most of the people, that can be prevented with lifestyle modifications. So my research work is actually devoted more towards the prevention than actually on the other sector. You will also say that, for example, I was by the European Union, I was commissioned to lead a group we called the Network of Excellence on Immigration Diabetes, because if you look in Europe, diabetes is unproportionately higher in the people who migrated there compared to this local population. So the prevention in the immigrant communities, prevention in general, this prevention can be achieved. You can achieve about 80% reduction in terms of occurrence of diabetes simply by lifestyle modifications.
Wow. Oh, thank you so much. This is great work, great work. Thank you so much for your hard work, for focusing also on research and not just on your medical background, to say you just want to see patients when they come to the clinic. Also getting involved even at conferences, you learn of different things. When people are presenting, you learn of different things. What can work in Europe may not even apply in Africa, because we have different circumstances, we have different environments and different systems that we use. Even our healthcare systems are extremely different. People here struggle to get, for example, medication, but people in Europe, for example, in the UK and England, people get everything for free. So thank you so much you have worked in different countries, you have stayed in different countries, and you know the kind of problems or the challenges that they face, and also trying to change the way in which even the IDF operate, because for all the challenges that we are facing or that we're experiencing, that we'll continue to face, they will require like new approaches, new ways to do things. You cannot solve different problems with the same idea, same solution. We need to change. We need to be adaptive and to move forward. What are some of the challenges you have faced in organizing diabetes care in resource-constrained societies, and how have you addressed these challenges?
I think that one of the biggest challenges that we have, that is the policies. That the policies that we develop, for example, today we are here, and I was very honest to talk openly with many of our colleagues, that the policies that is developed in a context which is far from Africa. The policies that you develop without its context, how do you think this will be implemented? I want to clarify that I'm not blaming any people. People trying to do their best, but their understanding of a problem is different than what is happening in, for example, in Africa or in parts of Asia, for example. It's mainly Europe, North America, and Europe-based places that where we develop the policies. So to make the policies, or for example, policies where, for example, people from Africa, and actually if you say that we have 3 representatives from Africa in our book, it doesn't solve the problem. Because you know that every society has its layers. So for example, then who would be in that committee? Some professors from some university. Do they share the challenges that the people on the ground, for example, a farmer who doesn't have the money to feed, for bringing the money for his 5 children, including buying the insulin for 1 children who happens to be type 1. He doesn't face that problem. So by bringing that person over there is not solving the problem. It is simply giving the makeup to say that, okay, we have people from Africa, we have people Asia, so then we have solved the problem. We have not solved the problem. But I do not have a solution. How do you get these people involved at a grassroots level to make their own policies, which is adaptable and which can be implemented at a national or an international level. So that is the biggest challenge, and that is the kind of future. I come from a poor country, as I said, that originally I'm from Bangladesh, even though I live in a rich country. But there are many illiterate people. Literacy and poverty goes hand in hand. As we have discussed many times, that non-communicable disease and poverty is also related. Okay, so how do you get an illiterate, poor man to give them the voice in the first place and to involve them in the policy making? I do not have any answer, but I think we'll have to go there if we have to solve the problem at that level.
Oh, this is brilliant. Thank you. It's quite an eye-opening, trying to reach out to everyone who has a solution. If you think we can collaborate, I think we need to work together to try to address these issues, especially the policy issues. They have been the major topic here. We can put a hashtag to that to say policy needs to change. The government, these are the people that make policies that will affect us. Even though we might attend conferences in Europe, you will hear good things, good solutions. But if your policies in your country don't change, it might be difficult for you to get the same care that people in Europe are getting. So I think it's the issue to do with the policies, and because some of the things are just easy to change, but it should take the policy for everybody to get involved, and so that we can change the narrative that we need. So thank you so much. Now I think we are focusing on the last part of our segment, the future of diabetes care. How do you envision the future of diabetes care evolving, particularly in terms of prevention, which is a major area of interest, on prevention strategies and technological advancement in the future?
Honestly speaking, I think that as long as we do not solve the problem of prevention, we will not be able to solve the problem of diabetes. Number of people with diabetes will increase to the point that it will not be possible to provide care. Or, for example, if you look in research-constrained societies, we do not have the capacity or we do not have the economy to provide care to so many people. Even though we say that I have money, but those people with money, these numbers will also grow. And so even the people, I think that they will not have the accessibility to have a kind of hospital bed or something like this. Unfortunately, the prevention is not getting the priority. Prevention is still a word done by WHO or IDF or some NGOs. But in reality, on the ground, we have to change the medical education. We have to change the medical people on the ground for prevention. We have to bring the industries to support these initiatives. We have to have 3 components in place. It is not only the responsibility of the industry, it is also the responsibility of the government. It is also the responsibility of the civil society. So 3 components will have to be in place to make a statement that we want to prevent. And there, I think that in terms of quality of care, those people who can afford it, the guidelines are coming continuously. And it will come continuously. New drugs will come because it's a good business. So I say that in terms of quality of care, we are already in the path that will go improve those who can afford to pay and get it. But we have learned the experiences of sharing the burden. For example, from COVID-19, the vaccine distribution. Have we forgotten this story?
No.
No. So we see that when the new intervention comes, who benefits from this new intervention.
Right.
So we are always at the back. Therefore, I said that the people at the back level will have to get involved in the policy making. Unless we can do it, there will not be equal distribution or equity in terms of the distribution of accessibility to care, even though it is available. I'm not very worried to see that, for example, how the quality of care will improve, but I'm more worried that those people who cannot pay, what is the system that could be in place to make sure, how can we make sure that we still cannot put, for example, insulin is a human right. Without this, you will die.
Yes.
Right. So we are not yet there. So how can we make the care for people with diabetes a human right?
Right.
So that is the biggest challenge, I think, for future, not to secure the quality of care.
Right. Wow, this is a great. Thank you so much for that perspective, for sharing that. So I think maybe our last question would be for the future of diabetes care. Like, what would be your advice that you would give to the healthcare professionals and policymakers looking to improve diabetes care in their communities?
As I said, that they will have to feel that the whole medical education needs to be readjusted. Right. I would say it should be readjusted in terms of the responsibility as a member of the community. That the doctor should not feel that we are the privileged class, but the doctor should have the feeling that we have an opportunity to serve, not that we should have a kind of luxury life. We are a class of opportunists.
Right.
We should have a kind of responsibility for this, and that should be the medical education itself should be training. Other thing is this, that government policies, again, you see that, for example, most of the doctors who are there in the big cities.
Right.
If you look at the countryside, if you see that it's a disproportionate. If you look at the number of people for one doctor compared in the big cities compared to the rural area. So it's the government's responsibility to make sure the doctors also reside there.
Right.
But doctors are also human, like any other human being. So you have to give them the opportunity. For example, their children's education, because many doctors complain that if I live in the countryside, my children don't get education.
Right.
So government will have to provide the facilities that you should have this. For example, if you look at European community, if you live in the countryside or in the big cities, there's no differences in terms of the quality of the school or the treatment pattern. And this is something that the biggest challenge is that, of course, we always talk about the resources, but the resource is always a question of priority. So if you give the right priority, the resources will be made available. And so therefore, I think that this is a kind of priority the local government should do, that how to bring the service to the people at the grassroots level.
Right.
And that is the future challenges I will leave to the coming generation.
Thank you so much, Professor Hussain, for your dedication, for sharing your insights, your expertise with the Global Diabetes Insights. I'm always referring to the compact because that's what we have here. But thank you so much for your insights, for your inspiration, even to the healthcare professionals, policymakers. Maybe take a listen to this because you're listening from the IDF president. Thank you so much for dedicating your time to do this with us. We cannot thank you enough. And with all being said, we would rest our case. Thank you.
Thank you.